I want to introduce our next speaker. Dr. Miri Kim has recently joined us from Yale, and we are thrilled to have her. I recently found out that we have the same taste in music when we realized we were going to the same concert, so I've been to a concert with her already, which is fun. But also she's, in addition to being, a fun person with good music taste, a phenomenal surgeon. I've been so impressed already just seeing, the care that she exhibits for her patients and how pleased they are with her. And so we are just thrilled to have her here. I asked her to speak on one of her least favorite subjects, because I didn't know, but she'll be telling you about hydrocephalus, which, we do encounter in our patients and is part of many people's journey. And so I thought maybe it would be useful to hear more about that from a surgeon. So thank you.
Excellent. Great. Awesome. Thank you for that really kind introduction, and I'm glad to hear that patients are having a good experience with me. I would like to talk to you guys about a topic that it is one of my least favorite subjects to deal with, mostly because it's such a challenging pathology, and there's so many different ways that patients are affected by this. Welcome. It's so great to see all of you guys out here and to meet you and, get to know you and hear your stories about your journeys with this disease. But just very, very briefly, I wanted to go through what it means to have hydrocephalus and then the implications of having a shunt. Okay, great. So how many people here are familiar with shunts and everything about shunts? We have one hand up. Yeah, a couple people. Great. So I want to talk a little bit about the background information about brain anatomy and the spinal fluid, especially in the way that it travels, because the brain itself has these normal fluid-filled spaces, and the brain is also cushioned by the fluid that it's sitting in, and that's the spinal fluid, the CSF. And so, you can see in this color drawing, is this the green here sort of represents the shape and the space that are called the ventricles, where the spinal fluid is greatly housed. And it acts as a cushion. It acts as sort of a plumbing system for the brain. So it's a waste management, if you will. It removes any metabolites and things that the cells are generating throughout the day. It has sort of a known path that we know, and it flows from the inside, it goes out, it goes down into your spinal cord and your spinal column. So if you know anybody who's had a spinal tap, they're really accessing this space and getting fluid that your brain is bathing in. So does anybody want to hazard a guess as to how much CSF is in your central nervous system in any one time? No? Okay. A liter? Okay. What's that?
All of it.
All of it. So the brain and spinal cord actually only holds about 150 cc's of CSF at one time. Do you know how much CSF is produced in a day? Does anybody want to guess? Okay. It's about 3 or 4 times that volume. So it makes about 400 to 600 cc's a day. And just for reference, like a can of Coke, it's just over 350 cc's of fluid. So your brain is constantly making this fluid. It's constantly cleaning out those cells. It's constantly washing your brain fluid. And so, of course, when we think about hydrocephalus, like what does that mean? It's water on the brain. And so it's a buildup of fluid in the brain, especially in the ventricular system, and then it can cause a lot of increased pressure on the brain and the neurons and all the tissue, and it can be very damaging. So when we think about hydrocephalus, right, this is an MRI of what is a reasonably normal-sized ventricular system. When you go from this scan to this scan, then what happens, right? A lot of people will present with headache. Sometimes they're sluggish. Sometimes they can't get out of bed. They might be obtunded. In other cases, people might have some difficulty with gait and balance. They might have difficulty with controlling their urination and their bladder. Sometimes they'll have blurry vision or memory difficulty, and a lot of these symptoms are incredibly variable. And sometimes it's related to the onset of when your ventricular system starts to back up with all this fluid. So what can cause hydrocephalus? I like to think of it in three different buckets. It's kind of like, I like to use the sink analogy. So whoever comes and sees me in clinic, they'll probably have heard this before. But one is through obstruction. The other one would be through overproduction, and another one through underabsorption. Right? So if you have a sink, it has a fixed volume of fluid. And so that's going to be that 150 cc's of fluid that it'll have. You have your drain and you have your faucet. So there's an input and there's an output and then a bucket. So if you have an obstructive pathology, then that means that the outflow is going to be blocked and you can't get that fluid out, right? But unlike a sink where you can just overflow, your skull is an enclosed space. And so what ends up happening is your ventricles get big, the pressure in your head gets much higher, and then it makes your brain very unhappy. The other way that you can have hydrocephalus is through overproduction, where you have your sink, the drain's completely fine, but then for some reason you just decide to turn up the faucet like completely and you're just blasting water in there. And then at some point, the drainage probably can't keep up with how much water is going into the sink. The last bucket is underabsorption, which would be the equivalent of you have the normal faucet, it's flowing at a normal rate, but the drain is just kind of clogged. It's draining slowly. And so even though you're doing all the normal production of water, it doesn't get drained appropriately. And so that can cause a discrepancy between how the water is, stored in the sink or if it's overflowing or anything like that. Does that make sense? Okay, great. So from a tumor perspective, right, like what can this mean? Sometimes hydrocephalus can actually be caused by the tumor itself. There's a mass that's blocking the way that your CSF is normally flowing. Sometimes the tumor itself might cause, an overproduction of spinal fluid. And then sometimes if you have surgery, if there's any bleeding or elevated protein content, it can kind of start to plug up the way that your CSF is normally absorbed. And us as surgeons, we have to take all of these things into consideration because if that spinal fluid, if the flow is abnormal or if we change the dynamics of that absorption and production, then it can have a lot of implications for the patient. So how do we treat the hydrocephalus? And so what we want to do is move that spinal fluid away and find like a second drainage mechanism so that all the plumbing is working so that you're not spilling all that fluid out of the sink. And so we just have to be very careful about how we do this because there are so many different ways that we can have diversion for that fluid. And so there's two ways that I like to think about it. One is more of a short-term solution, something that you just kind of need for a little bit of time to, help the patient settle down from surgery, let the brain sort of figure itself out again. And then there's the pocket of more permanent and durable solutions. So the temporary ones would be through a lumbar drain or external ventricular drain. I'm not sure if you guys are familiar with these terms, but a lumbar drain is basically a catheter that goes down into your spinal area, and then it'll drain fluid. And because you know that all the fluid spaces are connected between the brain and the spine, you're able to drain fluid that way. An external ventricular drain actually goes into the ventricle, and it comes out from a tube on the head, and you can drain it into a collection system that's outside of the body. But of course, you can't have these bags that hang outside of the body just collecting fluid from your brain, so we have to have other ways of dealing with that. And that's where all these different ventricular or lumbar space tubes have to find another place to deposit that fluid. And so there's a ventriculoperitoneal shunt where it goes into the belly. You can have ventriculoatrial shunts where it goes into the heart. You can have lumboperitoneal shunt where it goes from the back into the belly, or you can have lumboatrial shunts that go into the heart. You can also have it go into the lung space and have a ventriculopleural shunt as well. There's also a new technology that's kind of coming out that's still in clinical trials and not used for tumors, but more for normal pressure hydrocephalus called the E-shunt, where they go in through the blood vessels and create another way to have the CSF flow out of the brain. But that's still pretty experimental. I don't think it has a home quite yet in the neuro-oncology field. So there's a lot of different types of shunts, and you can have shunts that you can program and change the amount of fluid that it can flow through, or you can have a fixed pressure shunt, which stays a single pressure, and every time your pressure in the brain exceeds that, it'll start to drain fluid. And so if you have a programmable shunt, these are kind of nice because you can have an outpatient clinic visit. We put a little magnet up to your head, change the setting, and then see how your ventricles respond. So whenever we say we're doing a shunt adjustment, it doesn't mean you have to go back to the operating room. It doesn't mean that we have to cut you open again. We just kind of futz around with your head a little bit. Yeah. Has anybody had a shunt be programmed? Yeah. So these are just some examples of shunts that we can see. And on an X-ray, you'll be able to see your valve. You can see your catheter tubing. You can see how everything connects from your brain to your belly. And it's kind of cool when we look at it. And sometimes if your shunt malfunctions, then an X-ray is really helpful so that we can either see if it's broken, if it's disconnected anywhere. You can even check the setting with an X-ray so that if you don't have a shunt checker, let's say you're traveling somewhere and they're like, oh, we don't have this kind of shunt. You just get a single shot and you can see what the setting is at. And that's very helpful too. So surgery for a shunt, right? Nobody really wants to go and have another surgery after they've had a brain tumor surgery. It's really not, like a super easy peasy, like walk in the park kind of thing. It's not the most challenging surgery to do, but there are a lot of things that we have to think about. So major risks would be infection and bleeding. There's a risk of having the catheters that not go into the right place. If you go in from the head down to the belly, then when we're in the belly space, we have to make sure that we protect all of the contents of the abdomen too. We have to make sure that there's no injury to the bowels, that the tubing is going to be inside of the peritoneal space instead of stuck in a layer in between the skin and the abdomen. And sometimes, even if you have everything completely perfect, your body might have a reaction to these things and cause little collections of spinal fluid or pseudocysts to form in the belly. And all of that can be a means of having to go back to the operating room to explore the shunt, to make sure that everything is flowing from head to toe, like completely fine. And so, of course, this is to shunt or not to shunt, right? This is a very important discussion that you have to have with your surgeon. And if you're a patient who's had a tumor or, something that's really just impending obstruction, it's really important to know what the risks are, how it's going to help you. And then, nobody's super excited to be sitting in the neurosurgeon's office. Nobody's like, hey, sign me up for brain surgery right now, or I just had a brain surgery, I want a 2-for-1, like give me a shunt. Nobody really wants that. So making an informed decision, understanding the need for it and why you need to get one is really important. And just, ask questions, make sure that you communicate, make sure that you have the answers that you're satisfied with, because really these shunts are important to palliate any of these symptoms. So if your plumbing system is plugged up, then, hey, if we can't fix the normal tubing, then maybe we can help you by providing a side tubing and then get you on your way. So with that, that's shunts in a nutshell. Yep.
2 questions. So where's the CSF normally go?
So normally it's just kind of reabsorbed within the system. It's created in the brain, with the choroid plexus, and then as it circulates, it's sort of reabsorbed through the venous system, and then it's, absorbed back into your bloodstream, just naturally. It's all happening within that ecosystem.
And it makes the round trip down the spine?
Yeah, it just kind of washes around and travels around there.
And my second question is, why is that your least favorite topic?
Oh.
You seem very good at it.
Well, it's one of my least favorite because there's this little thought in neurosurgery where it's the 1% of shunts will cause the 99% of problems. And so it's a small population of people who have so many malfunctions over and over and over again, and that makes it really difficult. So if you have a shunt and then it breaks apart, or if you have a shunt and you get an infection, or you have a shunt and your abdomen doesn't like it, you have to decide, where do you put it? Where does the new catheter go? What do we do with the old catheter? And if you have a simple complication, or what seems like a simple complication, such as a simple wound infection, the consequences of that can be as severe as a devastating meningitis. So from a technical standpoint, it's not the most challenging surgery to do, but there are implications that can be very important to consider.